Good afternoon, sir.
Good afternoon. Can you hear me?
Yes, sir.
Okay. So I will try sharing my screen. Can you see the slides?
Yes, sir, it's visible.
Yes. Okay. Is it time?
Sir, we can begin.
Okay.
Welcome all to the second session of IB class on the topic cardiac diseases, history and examination findings. Over to you, sir.
Okay. So welcome all. Since the topic we started to discuss is a very vast topic, that is why yesterday I decided to split this. Otherwise, the problem is that your attention span will be lost and you'll be too much confused and it will be difficult for you. So that is why I decided to divide the topic into two parts. And initially, we discussed the basic approach as well as we discussed about ischemic heart disease, valvular heart disease, various types, and congenital heart disease. So the part we covered in the last topic. And this is the second part. Here we are briefly going through the rest of the cardiovascular system diseases. Actually, it won't be that much exhaustive because the common ones that is kept for the exam are the ischemic heart disease, valvular heart disease, and the congenital heart disease. But here in this part, we will deal with some important topics like infective endocarditis, rheumatic fever, like that, and various cardiomyopathies. So, moving on to the slides. Now, first, next heading is the cardiomyopathy. Okay. So, if you are wondering what is a cardiomyopathy, it's a cardiac muscle disease. Okay. There are different types, as you can see from this picture. The important ones, one is a dilated cardiomyopathy, where the heart muscle is stretched and weakened, and it produces an enlarged heart, and patient goes into cardiac failure. Then the hypertrophic cardiomyopathy, where the septum is hypertrophied. There is a thickened ventricular septal hypertrophy and resulting in a left ventricular outflow obstruction. Third one is a restrictive cardiomyopathy, where the ventricles becomes wall of the ventricles becomes very stiff and it will not relax properly, and that may result in features of cardiac failure. And finally, a rare type called arrhythmogenic right ventricular cardiomyopathy, where the fibrous tissue or fatty tissue replaces the muscular wall and results in arrhythmias. So these are the important ones we have to discuss. The first one is the obstructive cardiomyopathy. So as you can see in this picture, this is the normal septum. Here what happens there, you can see in this picture what happens, the septum hypertrophies. This is called the asymmetric septal hypertrophy. This asymmetric septal hypertrophy protrudes into the left ventricular outflow tract and results in obstruction of the blood flow from left ventricle to the aorta. So it behaves something like an aortic stenosis, because aortic stenosis actually happens in this valve, but this is actually a subaortic stenosis, otherwise called subaortic stenosis. Okay. Now, because of this problem, it behaves almost like an aortic stenosis. The blood cannot flow into the aorta, and the patient may develop features like exertional angina or syncope because of this problem. And the importance of this is that sometimes this may, so this is the hemodynamics. So why? So many times students may be wondering why this is happening, why a hypertrophic cardiomyopathy develops. It's actually said to be mutations in the gene. There are so many sarcomere proteins, like your myosin heavy chain, myosin binding protein, troponins, etc. There are mutations in these genes encoding these proteins, and this leads to myocardial disarray, and that's the basic reason for this hypertrophy. So there is LV hypertrophy and septal hypertrophy, and this results in outflow tract obstruction, decreased cardiac output, diastolic dysfunction, and the patient goes into systolic dysfunction later. But on the other hand, the myocardial disarray triggers electrical conduction abnormalities, and the patient may develop arrhythmias. And one of the important history you can elicit in suspected HOCM is a history of sudden cardiac death in relatives. So if you have a family history of sudden cardiac death in young patients, you have to strongly suspect, because this is a mutation, so it can be genetically transmitted. So if you have a history of sudden cardiac death in family, you have to always suspect hypertrophic obstructive cardiomyopathy. You might be remembering what happened yesterday. That is, the actor Puneeth Rajkumar suddenly collapsed while exercising, and he expired. Okay. So similarly, recently we had another footballer named Christian Eriksen also happened to collapse while playing the football. These people are apparently healthy and they don't have any previous illnesses. Okay. But sometimes an undetected hypertrophic cardiomyopathy may be the cause, while suddenly the patient exerts, the LV outflow tract obstruction increases, and suddenly this generates some arrhythmias, and the patient collapses and dies there itself. Okay, so it's a dangerous disease. So whenever you are if you have any history of syncope or any history of palpitations in the past, before going into exercise or going into some gym, always have a cardiac evaluation, because otherwise sometimes the exertion can trigger an arrhythmia, and that may result in adverse problems. So, and the findings you can get in the HOCM is the pulse is described as a jerky pulse, and because of this peculiar apex, you may get a finding called the double or triple apex. Multiple apical impulses may be palpable. You can get a fourth heart sound predominantly because of the concentric hypertrophy of the heart. And once the cardiac failure occurs, you may get a third heart sound. You can get a late systolic murmur. You may get something like mimicking the aortic stenosis. You may get a murmur. The patient can have atrial fibrillation also. So these are the findings you may get in hypertrophic obstructive cardiomyopathy. So this is a condition very much closely mimicking aortic stenosis, and it can present as family history of sudden cardiac death. So this is a very important condition to be diagnosed. Otherwise, the patient can have serious complications. The second one is dilated cardiomyopathy. So unlike hypertrophic cardiomyopathy, here you can see the heart wall is enlarged and thick. So it is something like what happens in a regurgitant lesion. The heart becomes enlarged, and there is a left ventricular dilatation and thickening happens. And this can lead on to even root dilatation and a mitral regurgitation. Everything can happen because of dilated cardiomyopathy. Now, why this happens? Because there are numerous theories behind this dilated cardiomyopathy. It may be genetic factors or viral infections affecting the heart or some autoimmune processes. All these lead to myocardial damage, dysfunction, and finally dilated cardiomyopathy. So, numerous etiologies are proposed for the dilated cardiomyopathy. Now the hemodynamics, as you can see, that it is when you compare, this is the hypertrophic cardiomyopathy. You can see the septal hypertrophy. While in dilated cardiomyopathy, what happens is basically a dilatation of the ventricle. So what happens initially in the hypertrophic cardiomyopathy is a diastolic dysfunction because the ventricle wall cannot relax and accommodate the blood during diastole. While what happens in dilated cardiomyopathy is predominantly a systolic dysfunction because ventricle is not able to eject blood into the aorta because of the weakened ventricular wall. So this patient develops biventricular failure, features of biventricular failure. The symptoms will be like features of cardiac failure only, like fatigue, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, edema or abdominal distension, which is suggestive of a right ventricular failure. So this right and left ventricular failure combined together. So that is what is happening in a dilated cardiomyopathy. So the patient may range from anywhere from an asymptomatic patient to a decompensated heart failure. And this can also result in mitral regurgitation also. Because of the dilatation of the root, it can produce mitral regurgitation. Again, this also there's an increased risk of arrhythmias like hypertrophic cardiomyopathy. Now the third one, it is less important, it is less commonly seen, that is a restrictive cardiomyopathy. Restrictive cardiomyopathy, what happens is that the ventricular wall becomes very stiff. So ventricular wall becomes very stiff and rigid so that you cannot receive the blood properly during the diastole. So the ventricle usually develops a diastolic dysfunction. This leads on to pressure changes in the left atrium and finally lead on to features of cardiac failure. So in this cartoon, you can see the left ventricle muscle mass becomes very stiff. So it will not allow the blood to flow. There is a diastolic dysfunction and finally the heart failure happens. Now, regarding the etiology, there are numerous systemic conditions which can produce restrictive cardiomyopathy like amyloidosis, sarcoidosis, hemochromatosis, post-radiation, Loeffler syndrome, etc. So all these conditions, these are all rare conditions. That is why restrictive cardiomyopathy is not commonly seen. It is a rare condition seen with some systemic conditions. You can produce this restrictive cardiomyopathy. Again, patient will have features suggestive of cardiac failure only, like fatigue, dyspnea on exertion, angina, thromboembolism, paroxysmal nocturnal dyspnea. All these things are features suggestive of a cardiac failure only. So it depends upon where is the failure. Usually right side is commonly affected. In that case, you will get a features of right ventricular dysfunction, like an elevated JVP, a congestive hepatomegaly, or a pedal edema, ascites. All these things can be seen in restrictive cardiomyopathy. Now, the fourth one I was talking about was the arrhythmogenic RV cardiomyopathy. What happens is a very rare condition, but of interest because this can also trigger sudden cardiac deaths. That is why I included this. The sudden cardiac death sometimes can occur with arrhythmogenic RV cardiomyopathy, where what happens is that the ventricular wall is replaced by fat and fibrous scar tissue, and because of this, predominantly affects the right side. And this can trigger many arrhythmias and the patient may suddenly develop cardiac arrhythmias and even death. So this is a very important arrhythmogenic cardiomyopathy. It's a rare condition, but it can produce sudden cardiac death. That is why I'm including this. And it produces a characteristic finding in the ECG, which is called the epsilon wave. Sometimes this is asked as MCQs. Epsilon wave is seen in which condition? You can see in this the ECG wave. After the QRS complex, there is a prominent wave called the epsilon wave. So this is very characteristic of arrhythmogenic RV cardiomyopathy. I'm including one more interesting cardiomyopathy, which is called the Takotsubo cardiomyopathy. It's actually why it is called Takotsubo, because Takotsubo is actually a Japanese octopus trap. Okay, you can see this picture. It's a peculiar pod which used to trap octopuses in Japan. Okay, so because it has a peculiar shape, the heart assumes that peculiar shape. Okay, so there is an apical ballooning. There is something called apical ballooning, and this apical ballooning, this characteristically resembles this Takotsubo. That is why it is called a Takotsubo cardiomyopathy. Now, why this is becoming important is that this is otherwise called the stress-induced cardiomyopathy. You might have seen various dramatic scenes in films, like hearing someone near death, a person collapses after clutching to the chest or something like that. Something like that happens here. Stress-induced cardiomyopathy. Otherwise, the patient usually presents with features of cardiac failure, otherwise called the broken heart syndrome. Because of intense emotional stress, what happens is that sympathetic activation can happen, and there is a catecholamine release, and this catecholamine release damages the heart, resulting in apical ballooning, and this produces this peculiar type of cardiomyopathy. It's called the broken heart syndrome or Takotsubo cardiomyopathy. This is not of no need to study this, just for information I am telling this, usually asked in something like quizzes or something. So that we finishes the cardiomyopathy. We have covered hypertrophic cardiomyopathy, then dilated cardiomyopathy, restrictive cardiomyopathy, and the rare two types of cardiomyopathies. Now coming to myocarditis. Okay, so myocarditis means, as the name implies, it is inflammation of the myocardium, and it is caused by an infection. So if you think of an infection affecting the heart, that is myocarditis. Okay, so as infection comes, as comes the infectious etiologies, there are numerous ones: viral agents, parasitic, bacterial, fungal, protozoal, all these can produce. In viral agents, you can see adenovirus, Coxsackie virus, herpes virus, numerous viruses, HIV, everything can affect. Parasitic agents, bacterial agents, and fungal agents, and protozoal also. You might have studied the Chagas disease, which happens due to Trypanosoma cruzi. Okay, so this is a type of myocarditis. So among these infectious etiologies, the common ones are the viral agents. Now coming into non-infectious etiologies, maybe toxins, drug hypersensitivity, or immunological, like a vasculitis conditions like SLE, sarcoidosis, Takayasu, venous granulomatosis. There are so many conditions. So all these conditions can affect the heart. And this picture actually is showing a COVID. Okay, so COVID can also produce myocarditis. So COVID sometimes patient presents with features of myocardial inflammation. So that is called COVID myocarditis. So all these infectious agents or rarely non-infectious agents can damage the heart, and this is called myocarditis. Now, how will they present? No, so it can have varied presentations. Okay, the patient may, this is actually showing this inflammation of the myocardium and resulting in cardiac damage. So the patients can have varied symptoms. They can have chest pain, they can have dyspnea, they can have palpitation. All the cardiac symptoms are possible. And sometimes when you see the patient can have ECG abnormalities, like mimicking a myocardial infarction, the patient can have arrhythmias, like it may be an SVT or a complete heart block or ventricular tachycardia, ventricular fibrillation. All these things can happen because it is inflammation of the myocardium. Again, the patient may have syncope and can have sudden cardiac death also here. And sometimes the patient may present with cardiogenic shock also. So unexplained cardiac failure, you have to always think of this possibility, myocarditis. So it is basically inflammation of the heart due to infectious and non-infectious agents. It can present in any way, like it can present with valvular lesions, it can present as arrhythmias, it can present as ischemic heart disease, it can present as cardiac failure. Like there are so many presentations due to myocarditis. So the patient can have any type of findings, like maybe tachybradycardia, features of cardiac failure may be there, mitral regurgitation can happen. So many findings, so non-specific. So it's a myocarditis can have a lot of non-specific findings. So name any finding in the cardiovascular system, you can theoretically get that in myocarditis. So findings are basically non-specific and depends upon what type of damage heart has, the infectious agent has formed in the heart. Now coming to the next important topic, this infective endocarditis. It is very important for you because most often it is asked as sometimes as an essay, or sometimes it may come as a complication of valvular heart disease, or all these things. It is very important. So as the name implies, it is an infectious microbial infection of the endocardial or the endothelial surface of the heart. So it is characterized by a thing called vegetation. You can see in this picture, underneath the wall, there is something called vegetation. And vegetation is a amorphous mass of platelets and fibrin in which abundant microorganisms and scanty inflammatory cells are enmeshed. So all these things, fibrin, platelets, bacterial agents, scar tissue, everything together forms the vegetation. So that's a classical feature of infective endocarditis. And the method to diagnose infective endocarditis, you are using a criteria called the modified Duke's criteria. It's very important because most often usually it is asked in the exams. So you have to learn that modified Duke's criteria. You have a major criteria and a minor criteria. Major means two major criteria are either blood culture positive for infection. Whenever you are suspecting infective endocarditis, you take 3 samples of culture and you send it to look for any growth of organisms. Also look for echo, you take an echocardiogram and look for presence of vegetation. That is the evidence of endocardial involvement. So blood culture positivity and vegetations in echo. These are the 2 major criteria. Then minor criteria is a predisposing factor that I will tell you what are the predisposing factors. then presence of fever, then vascular phenomena, immunological phenomena, and microbiological evidence. Vascular phenomena means features like embolic manifestations. As you know, infective endocarditis is a condition which can predispose to various vascular embolisms. So the patient can have arterial emboli, they may develop stroke, septic emboli, pulmonary infarction. The brain can develop something called a mycotic aneurysm, and the patient can develop intracerebral hemorrhage and the painless skin lesions called the Janeway lesions. So all these are vascular phenomena happening in infective endocarditis. And the immunological phenomena are glomerulonephritis, painful nodules in the fingertips, which is called the Osler's nodes, retinal hemorrhages, which is called the Roth spots, and all these things are suggestive of immunological phenomena. And microbiological evidence is not as in the major criteria, but there is evidence of presence of organisms. So these are the major and minor criteria, and 2 major criteria, or 1 major, or 3 minor, or 5 minor criteria qualifies the diagnosis of infective endocarditis. Okay, so this you have to learn very thoroughly because it is very commonly asked. What are the major and minor criteria, and what is this Osler's, Janeway lesions, Osler's nodes, Roth spots, etc. So are very commonly asked in the exam. Now, in risk factors, I have told the predisposing factor, the first minor criteria. It is basically an underlying heart disease. Like it may be a congenital heart disease, valvular heart disease, prosthetic valves, immunodeficiency, intravenous drug abuse, or any cause for septicemia. All these can predispose to infective endocarditis. In a patient, for example, in a patient who is having a prosthetic valve, a dental procedure done releases the bacteria into the circulation. It will affect the heart and it may produce infective endocarditis. So this is why you are giving some prophylaxis, infective endocarditis prophylaxis in some specific conditions. Okay. Now this is what is happening. So there is a bacterial source will be there, either a procedure or a surgery or a device or an infected needle, etc. And the bacteria reaches the bloodstream. And in the substrate, there may be an abnormal valve, and the valvular damage or prosthetic valve, there is a thrombi formation is there. And the bacteria will get into this thrombi and forms the vegetations, and that damages the valves, and that can produce valve damage like valve dehiscence, valve tears, rupture of chordae tendineae, regurgitant lesions. All these things are possible with infective endocarditis. You can see in this picture, this is a subacute bacterial endocarditis. So infective endocarditis can be classified as subacute bacterial endocarditis and acute endocarditis. Subacute bacterial endocarditis, you can see the inflammation is less severe. It is caused by the Streptococcus viridans. While acute endocarditis, you can see the very severe inflammation, which is commonly caused by Staphylococcus aureus. Okay, so basically, acute endocarditis is a dramatic presentation. Sudden high-grade fever and new onset lesion, valvular lesions can happen. While subacute endocarditis is usually patient presents as prolonged PUO, pyrexia of unknown origin, with cardiovascular symptoms. And it can produce, as I have described, it can produce a lot of complications like the valve leaflet can rupture, it can perforate, it can abscess formation can happen, aneurysm, fistula, damage to prosthetic valves, embolization, and it can also produce hemodynamic complications like acute MR or acute AR. And the patient may develop cardiac failure also. So that is regarding the infective endocarditis. So infective endocarditis is a very important topic. Whenever you are considering a prolonged fever, you have to rule out infective endocarditis by proper evaluation. And remember, the major criteria was blood culture, positive blood culture, as well as looking for vegetations in the heart. Now, the next class is the rheumatic fever. And again, you might have studied this rheumatic fever because we were discussing valvular heart disease, and rheumatic fever is one of the important etiologies for valvular heart disease. So what happens in rheumatic fever is that the group A beta hemolytic streptococci infects the throat, sore throat. This usually happens in people who are living in an unhygienic or overcrowded situations. The patient will have sore throat and fever, and followed by because the body is producing antibodies against this M protein and other proteins of the streptococcus. This cross reacts with the cardiac proteins, and that's called molecular mimicry. The mechanism by which a rheumatic fever affects the various systems. So it produces the joint pains, arthralgia, carditis, subcutaneous nodules, erythema marginatum, and Sydenham's chorea. So what you are seeing in this picture is otherwise called the Sydenham's chorea, which are dance-like movements. It is called the Sen-Vitus dance. Previously, it is described as Sen-Vitus dance. Okay, so this can also sometimes develop following a rheumatic fever. Now you can have erythema marginatum, migrating polyarthritis. So the polyarthritis is characterized by the feature of migratory polyarthritis. That means it will affect the one joint, then it will the inflammation subsides, and then it will skip on to the next joint. So that is how the polyarthritis happens. The next important findings, you can see this picture is that of an erythema marginatum. It's a very faint rash with a augmented central clearing. There will be peripheral will be more clear, and the peripheral will be more reddish, and the central will be more clear. This erythema marginatum is not seen in dark skin population. So Indian population is very less likely. You cannot see this erythema marginatum. You can see only in white skin people. And the subcutaneous nodules, you can see hard painless nodules over the extensor surface of the extremities is also very rare. So these are the major criteria. And what you have studied as the criteria is the modified Jones criteria. Okay, modified Jones criteria, you might have studied the major criteria as carditis, then arthritis, that is polyarthritis, chorea, subcutaneous nodules, and erythema marginatum. So these are the major criteria: carditis, arthritis, chorea, subcutaneous nodules, and erythema marginatum. While the minor criteria is polyarthralgia, fever, ESR or CRP elevation, and prolonged PR interval in the age, in the ECG. Okay. So this is the major and minor criteria. Now what happened in 2015 was there was a revision of this Jones criteria. And in case of high-risk population, in the case of high-risk population who is having recurrent streptococcal sore throat infection, various changes were made into the criteria. So you can see the changes were, first one is, in the arthritis, previously it was polyarthritis only. Now we are including monoarthritis and polyarthralgia also. So even if there is no arthritis, if arthralgia is enough or monoarthritis is enough for in the case of a high-risk population. In the minor criteria, you can see what happened is instead of polyarthralgia, monoarthralgia can be also taken as a minor criteria. So that's the changes that is made in revised Jones criteria in 2015. That is the latest revision. So this is the one that is most recent. Now in the carditis, what you get is something called pancarditis. Okay, so rheumatic fever involves all layers of heart. That is, pericardium is affected. It produces a pericardial friction rub. Endocarditis produces new changing murmurs, valvular regurgitant lesions, etc. And myocardial inflammation also. So it is pericarditis, myocarditis, and endocarditis. All these things happen in rheumatic fever. That is called the pancarditis. And one interesting finding you may get in active rheumatic valvulitis is a murmur called Carey-Coombs murmur. Okay, Carey-Coombs murmur is a mid-diastolic murmur mimicking the mitral stenosis murmur. But the importance is that there will not be any opening snap or loud S1 in Carey-Coombs murmur compared to the MDM of mitral stenosis. So it may be associated with a third heart sound. So the Carey-Coombs murmur is due to active rheumatic valvulitis, mitral valvulitis. Okay. So that finishes the rheumatic fever, briefly going into the clinical features. Now, arrhythmias is actually a very large topic. There are numerous arrhythmias. So I will be just limiting the discussion to atrial fibrillation only, because atrial fibrillation is a very important topic regarding, it is a very common finding. That is why I'm discussing atrial fibrillation a lot. So what you can see in atrial fibrillation is, normally the impulse originates from the SA node, and it is transmitted into the AV node through the interatrial pathway. So it goes like that. But here atrial fibrillation means the automaticity happens in multiple areas of atrium, so that the atria will start fibrillating. This atrial fibrillation is manifested as, you can see in the ECG, as a, here it is a regular sinus rhythm, here it is a irregular rhythm without any definite P wave. Okay, so this is the atrial fibrillation. And when you classify atrial fibrillation, you can classify it into newly diagnosed or first diagnosed AF. That means there was no history previously and it is coming for the first time. Next is the paroxysmal AF. Paroxysmal means the AF atrial fibrillation comes and it spontaneously disappears within 7 days. So within a period of 7 days, it completely disappears. Now it can be two types. Then next is a persistent AF. Persistent AF means the AF lasts for more than 1 week. Okay, so paroxysmal AF means AF spontaneously disappears within 1 week, while persistent AF means AF is persisting more than 1 week. Okay, so it can be classified further as early persistent and long-standing persistent. Early persistent means 7 days to 3 months, and long-standing persistent means 3 months to more than 1 year. Okay, so this is long-standing persistent AF. This is how you classify Paroxysmal AF means within 1 week spontaneous regression. Persistent AF means more than 1 week. It can be early persistent 7 days to 3 months and long-standing persistent more than 1 year. And there is something called permanent AF. Permanent AF means here the patient and the physician who treats the patient accepts that AF is present, and there is no attempt is made to revert it to a sinus rhythm because the patient is adjusted to that rhythm and patient goes on with AF. Always the patient will be having AF. So such type of patients sometimes may be coming to the OPD. They already have AF and their heart rate is always irregular. So such patients can also be there. It's called the permanent AF. Now, there are numerous causes for atrial fibrillation. You might have studied the common causes we already discussed yesterday. There is a mitral valve disease, myocardial infarction, then other conditions like hyperthyroidism. Thyroid dysfunction can produce atrial fibrillation. Alcohol can produce atrial fibrillation. So, heart failures, hypertension, numerous causes. Even a congenital heart disease, numerous causes are there for atrial fibrillation. Usually the symptoms is palpitation. So as you know, whenever there's a atrial fibrillation, the patient will complaining of palpitation. Usually a palpitation will be irregular type of palpitation. Usually even without exertion, patient may feel this palpitation. And the other symptoms are fatigue, dyspnea on exertion, and malaise. On examination, you may get a totally irregular pulse with apex pulse deficit more than 10. Okay, so when you count the pulse rate as well as the heart rate, you will see that the heart rate is more than pulse rate in a minute by 10. So that is called apex pulse deficit. And you may get a varying pulse volume, varying intensity of first heart sound. And if it is a mitral stenosis, as I already described yesterday, the pre-systolic acceleration will be disappearing from the murmur. So that's a change that is happening with atrial fibrillation. In the JVP, you may see an absence of A wave, because A wave in the JVP is caused by atrial contraction, and in atrial fibrillation, classically, the A wave will be absent. Now coming to the next class, that is hypertensive heart disease. Okay, so hypertensive heart disease basically can be two types. One is the systemic hypertension as well as the pulmonary hypertension. Okay, systemic, in this picture you can see what happens in systemic hypertension. There is a concentric thickening of the left ventricular wall. So it mimics something like an aortic stenosis or hypertrophic cardiomyopathy because a concentric thickening of left ventricular wall. So this is the systemic hypertension. What happens in pulmonary hypertension, you can see the thickening is mainly happening in the right ventricle, and this you define as the cor pulmonale. You might have studied what is cor pulmonale. Cor pulmonale is basically right ventricular hypertrophy with or without right ventricular failure due to a long-standing respiratory or chest wall disorder. So this is cor pulmonale. Okay. So as I have described, it can be of two types: systemic hypertension-induced cardiac disease and pulmonary hypertension-induced cardiac disease. Now, when you are discussing cor pulmonale, it can be acute or chronic. Acute means it occurs after a sudden and severe stimulus. For example, a massive pulmonary embolus comes and occludes, and this results in sudden RA-RV strain. There is no RV hypertrophy. There is no time for hypertrophy. So this is called goes into a right ventricular failure. This is called acute cor pulmonale. While chronic cor pulmonale is slowly evolving pulmonary hypertension that leads to right ventricular dilatation and hypertrophy. So that is the difference between acute and chronic cor pulmonale. So if someone asks what is the cause for acute cor pulmonale, the answer is a massive pulmonary embolism. So the physical findings you get in systemic hypertension and pulmonary hypertension. So let us see what is in systemic hypertension. The BP will be as expected elevated. And because of the concentric hypertrophy, you may get a heaving apex, loud second heart sound. Because of this, A2 is delayed, you may get a reverse splitting of the second heart sound. You may get a fourth heart sound. So you can imagine now in aortic stenosis as well as hypertrophic cardiomyopathy as well as in hypertension, you will get a fourth heart sound because all these conditions produces concentric hypertrophy of the heart and a diastolic dysfunction. If the heart goes into systolic failure, you may get a third heart sound or basal crepitation. While in pulmonary hypertension, because the right ventricle is enlarged, you may get findings like left parasternal heave and epigastric pulsation, palpable P2, loud P2, narrow splitting of the second heart sound, ejection systolic murmur in the pulmonary area, and a functional tricuspid regurgitation. So all these things can happen with pulmonary hypertension. A rare murmur is a pulmonary EDM, early diastolic murmur, and it is called the Graham-Stills murmur. All these findings you can get in pulmonary hypertension. Now coming into the second last topic, penultimate topic, that is the pericarditis, the pericardial diseases. The pericarditis basically is an inflammation of the pericardial lining of the heart, and it can be divided as acute, subacute, and chronic. Acute means less than 6 weeks duration, short duration. 6 weeks to 6 months is subacute, and more than 6 months is chronic pericarditis. So that is how you classify the pericarditis into acute, subacute, and chronic. Now there are the causes. There are numerous causes, so endless list. You can divide it as infections, tuberculosis cause is important. Then neoplasms, malignancies like primary or secondary. Primary cardiac cause like a myocarditis or a post-cardiac injury syndrome called the Dressler syndrome. All these things can happen. Autoimmune causes, various drugs, metabolic conditions, hypothyroidism is one important condition, and trauma. All these things can lead on to pericarditis. The characteristic thing is that pericarditis also presents with chest pain. So you have to differentiate that from myocardial infarction. So when a patient comes with acute chest pain, you have to differentiate between pericarditis and myocardial infarction. So as you know, the features are myocardial infarction produces an angina. We have discussed what is the typical findings yesterday. And pericarditis is actually a sharp stabbing pain, and it is usually there is a patient, it is radiating to back or neck. And the patient, the characteristic feature is that it is relieved on the sitting and leaning forward position. So if the pain is aggravated on the supine position, and if it is relieved on sitting and leaning forward position, this is characteristic of a pericardial pain compared to a myocardial infarction. This postural change is very important in pericarditis. The problem is that in ECG, pericarditis can produce an ST elevation. Now it is another cause for ST elevation. So you may be confused with being a myocardial infarction. So you have to carefully evaluate, differentiate between pericarditis and myocardial infarction. The classical finding that you may get in pericarditis is pericardial rub. So pericardial rub is actually a triphasic sound. Triphasic means it has got 3 components. Okay. So you have a ventricular systole, ventricular diastole, and atrial systole. So he has 3 components: ventricular component, systolic component, diastolic component, and a pre-systolic component. So all these things you may be sometimes mistaking this for some continuous murmur or other murmurs, but this is actually a superficial, scratchy, squeaky sound, and it is heard more superficially, and it's got 3 components. Okay, it's a triphasic pericardial rub. And to differentiate between a pleural rub can also be due to inflammation of pleura, and you have to distinguish that by asking the patient to hold breath. And if the patient holds breath, the pleural rub disappears, but the pericardial rub will be continuing even if the patient is holding the breath. So that's the difference between pericardial and pleural rub. The next is constrictive pericarditis. Another 2 condition which can happen is in pericardium is constrictive pericarditis. It is actually due to scarring and consequent loss of elasticity of the pericardial sac. So inflammation leads on to chronic inflammation, lead on to scarring of the pericardial sac. So the elasticity is gone. So it is like the heart is wrapped in some thick paper or something. So this the heart cannot expand and contract normally. So this results in features of constrictive pericarditis. As I have described, chronic pericarditis can be due to tuberculous, fungal, or parasitic causes, post-cardiac surgery, radiation therapy, collagen vascular disorders, uremia. So many conditions are there which can cause constrictive pericarditis. The patient usually presents with features of cardiac failure, predominantly right side. That is edema, elevated JVP, pedal edema. All these things can be present. Ascites is also present, and the patient can have features of diminished cardiac output also. And a characteristic sign that you will see is the Kussmaul sign. You might have studied of Kussmaul's breathing. Here is a Kussmaul sign. Kussmaul sign indicates that it is an increase in JVP during inspiration. Normally, what happens to JVP in inspiration is that it will fall during inspiration. Here it's a paradoxical rise in JVP during inspiration, which is called the Kussmaul sign. On auscultation, you may hear a peculiar sound called the pericardial knock. So these are the findings in favor of a constrictive pericarditis. Next important problem is a cardiac tamponade. Cardiac tamponade means pericardial effusion is so severe that it affects the contraction and dilatation of the heart. As you can see, the pericardial fluid gets collected here, and this thick amount of fluid restricts the movement of heart. This is the pericardial tamponade. Now, many times you will get a confusing regarding the findings, whether it's cardiac tamponade or constrictive pericarditis. So you have to remember, like, the cardiac tamponade will be having a classical finding called pulsus paradoxus. Okay, you might be remembering what is pulsus paradoxus. That means in deep inspiration, the systolic BP falls more than 10 millimeter of mercury and the pulse may be absent. So this is characteristically present in cardiac tamponade, while this is absent in constrictive pericarditis. And Kussmaul's, as I already told, is present in constrictive pericarditis, but is rarely seen only in cardiac tamponade. So this is the difference between cardiac tamponade and constrictive pericarditis. And JVP has an important finding called absent Y descent in case of cardiac tamponade. And coming to the last section, that is systemic diseases and cardiac symptoms. Okay, first and foremost is anemia. We were discussing actually regarding the first case. Remember the first case? We were discussing a case of anemia mimicking a cardiovascular system disorder. Okay, so why this happens? Because anemia produces peripheral vasodilatation. This results in increased neurohormonal activation, that is catecholamines, renin-angiotensin aldosterone, atrial natriuretic peptide, everything is stimulated. Renal blood flow is decreased, and this results in all these renin-angiotensin axis produces aldosterone, and there is a salt and water retention in the body. This leads to a high output state, or extracellular volume is increased, and the patient develops a high output cardiac failure. Okay, the left ventricular hypertrophy happens, and left ventricular dysfunction happens, and a heart failure can develop. So this all takes many time. So anemia, if it is suddenly happening, there is a blood loss, severe blood loss, the patient may develop heart failure. Or it's a chronic anemia, many times the heart has time for to adapt. So even in case of severe anemia, sometimes you may not see any cardiac failure because the heart has adapted to that particular condition. But it's an acute volume loss, the patient may sometimes go into cardiac failure. Okay, you can see left ventricular hypertrophy. Pallor should be carefully looked for. If there is a pallor, always think of an anemia presenting as a cardiovascular system disease. High volume pulse may be there, cardiomegaly, and you may hear even an ejection systolic murmur in the heart. That is called the hemic murmur, which can be confused to a something like an aortic stenosis or something like that. That is how the confusion comes. Always you can think that anemia can produce cardiovascular disease, and anemia may mimic a cardiovascular disease. So carefully, when you are doing general examination, you have to look for a pallor to identify an anemia-induced heart failure. Next important one is the thyroid and the heart. This can be also kept as a case, hyperthyroidism or hypothyroidism presenting as cardiovascular system disease. So hyperthyroidism causes tachycardia, hyperdynamic circulation, and a high output cardiac failure. So that is a classical presentation. Hyperthyroidism presents as tachycardia. As you know, it can be tachycardia. It can also result in atrial fibrillation. So hyperthyroidism can also produce atrial fibrillation, and it results in a high output cardiac failure. You can get even cardiac murmurs. So it's a flow murmur only. As in case of anemia, you may get a flow murmur. So don't think of it as a valvular heart disease. Sometimes there may be features of hyperthyroidism. You have to carefully look for the tremors, the tachycardia, the eye signs, the thyroid swelling, everything you have to look for, and then you have to make a diagnosis of hyperthyroidism-induced hypervolemic cardiac failure. Now, hypothyroidism, I already told, it can produce, sometimes can rarely present as pericardial effusion. It usually produces bradycardia. So this is how the thyroid affects the heart. And lastly, uremia. We have discussed a case where uremia was the problem. Then chronic kidney disease, because numerous factors can contribute to cardiovascular system disease. For example, the anemia which is coexisting, renin-angiotensin activation, chronic inflammation, various medications which are used, all can lead on to ventricular hypertrophy and cardiac failure. There may be hypertension, and that hypertension can produce heart failure. Like there are so many mechanisms to produce heart failure in uremia. Now, you have to also know that uremia, the urea is a cardiotoxin, so it can present as pericarditis. So it is one of the cause for pericarditis. And when you see, if you are seeing a chronic kidney disease patient with a pericardial rub, that means it is a uremic pericarditis, and that is a very important indication for doing a dialysis for the patient. So these are the common systemic conditions that presents with heart symptoms. That is, first one is anemia, second one is thyroid, and third one is uremia. Okay. So with that, we have finished the topic. We have covered the rest of the topics like cardiomyopathy today, the myocarditis, then the infective endocarditis, rheumatic fever, the atrial fibrillation, and we have covered the last portion, the pericardial diseases and the systemic diseases presenting as cardiovascular system disease. So that will finish the topic. So make sure that whenever you are dealing with a cardiovascular symptom, the first step is to identify which class of cardiovascular system disease it is. So always think of all these 11 classes of cardiovascular disease and think of which all disease may be present for this patient. And many classes can coexist. And natural history is very important. I have discussed natural history of many diseases, and it's very important. The evolution of symptoms is very important. And differential diagnosis should be considered before examination. So after hearing the history, before going to the examination itself, you should have some differential diagnosis, like whether it's an AS or hypertrophic cardiomyopathy or it's a myocarditis. Like that, you have to have some possibility in your mind. And also, you should know how to correlate your pulse, BP, JBP, apex, heart sounds, and murmurs. Because in short case, you won't have history, and you have to correlate all these basic findings, general examination findings, and system examination findings to arrive at a diagnosis. Okay, and you should have the confidence to face the exam. If you thoroughly study this topic properly, it will be easy for you in the exam. So hope you have understood, and thank you for the listening, and all the best to you.
Thank you, sir. With that, we come to the end of the session. We would like to thank Sreejith sir for taking this class for us, even during his busy schedule, hoping that it was a fruitful session for all. Thank you all.
Thank you, sir.
Thank you, sir.
Okay.
Thank you, sir.
Thank you, sir. Thank you, sir.